We will take a deep dive into the world of neurology. Today, we are very lucky to be joined by Dr. Amanda Jagolino-Cole. Dr. Jagolino-Cole obtained her medical degree from Jefferson Medical College and then went on to complete an internship in internal medicine and afterwards a residency in neurology at the University of Miami. She then went on to pursue fellowship in vascular neurology, and she currently works as a vascular neurologist at the UT Health Houston Neurosciences Center in Houston, Texas, where she's also the director of vascular neurology fellowship program. She is, in addition to this, also the director of the UT Teleneurology program and is also quite the prolific author and has been cited multiple times in leading journals such as Stroke and Neurology. Dr. Jacqueline-Cole, thank you so much for being with us today. We are very excited to learn from you. You may begin whenever you're ready.
Okay. Well, thank you so much for that very kind introduction. Give me 1 second to share. And just to double check if the slides are okay.
And the slide showed up for a moment and then they went away. If you maybe try to press it again.
How about now? Hmm.
I don't see the
Let me try it again.
perfect.
Yeah. Okay, great. All right, wonderful. Sorry about that technical difficulties. So, all right. So, I just want to say thank you for the opportunity to speak to you all about stroke severity and stroke scales. This is a topic that's very dear to me. I think it drives a lot of our decision making um, in stroke. I have no relevant disclosures. For this time period, I'd like to go over the existing stroke scoring methods, define levels of severity in acute ischemic stroke, and I'd like you all to be able to appreciate the nuances to stroke scoring and categorizing acute ischemic stroke severity and ischemic strokes in clinical practice, and then incorporate stroke scales and levels of stroke severity into your acute stroke care clinical decisions. I know that's a little bit different what's available wherever people are, but just thought we kind of dive into that. Just as a heads up, I referenced several classic older studies in this slide set. I have the references at the end. I just felt that these were really important to understand stroke scales and stroke severity. Additionally, some of the images they are referenced as if there's any questions to where they belong, you can always reach out to me. All right, so any grand round should start with a case, right? So let's just start with this question. Would you administer intravenous thrombolysis to a patient with an NIH stroke score of 2? And I just kind of want you to think to yourselves for a little bit. And this is an acute stroke. Let's just assume there's no contraindications, no major bleeding, no recent heart attack, or no recent stroke otherwise. Would you give IV thrombolysis to a patient with an acute stroke with an NIH of 2? If why? And if not, why not? And we can talk a little bit more at the end. And then really, what does your decision depend on? I think a lot of us are kind of probably like, well, it depends, you know? So it's important to think about what you're giving to a patient before you give it. So just so we're all on the same, level playing ground. Intravenous thrombolysis for acute ischemic stroke, it is used for acute ischemic stroke. In clinical practice, it does have a low risk, but a risk of both symptomatic intracranial hemorrhage, asymptomatic intracranial hemorrhage, and angioedema, as well as other hemorrhages, GI bleeding, and so on. Small risk, but still there. However, about a third of patients who receive this medication achieve independent ambulation. And the faster you give the thrombolysis, the higher rates of independent ambulation and discharge to home, lower rates of death, and lower rates of the side effects such as symptomatic intracranial hemorrhage. So in a nutshell, you have to make a decision that's very critical, high stakes, that could prevent death and disability, but also has a small risk of intracranial hemorrhage and swelling of the mouth. So it's obviously a decision you cannot take lightly. So let's get back to the case. As the decision is largely driven by, outside of contraindications, by the level of disability or severity of the stroke that the patient is harboring. So let's just get back to the case. So this patient, with more details, is a 67-year-old with diabetes, hypertension, congestive heart failure. They're in the ER within 1 hour with blurry vision, and they're in the time window. There's no other contraindications. Would you consider TPA for this patient? You're probably all thinking, well, I need to know a little bit more about what this NIH2 means. And so just to tell you what the neurologic exam showed, the patient presents with an stroke score of 2, which we'll go into in a little bit more detail, with a left visual field cut noted, and this is what they can see. Okay, so let's talk about the stroke scales, and we'll talk about the case at the end again, I promise. So there are a lot of different kinds of stroke scales, and they kind of sort of have evolved over the years, and and different ones are used for different things. They are used in clinical trials to compare baseline characteristics, but also outcomes among study groups primarily in research. There, again, are several different scales. The NIH the National Institutes of Health Stroke Scale is actually considered to be one of the most prognostic regarding outcomes and also has become most widely integrated into clinical practice. And there's different reasons for that. But you can see that these are some of the other scales or earlier versions. You can see that they all condense the usually very tedious neurologic exam, packaging it up in a way that can help you localize where the lesion is for the stroke, can help possibly characterize disability or severity, and we'll talk more about that in a little bit, and can be used really quickly to make critical decisions if needed. So a little more background on the current NIH stroke scale. It is very fast, so you can do the stroke scale in less than 7 minutes. It has high inter-rater reliability. It has high test-retest reliability. There's no difference whether it's an ER nurse or a neurologist or an ER physician. It's really good among different subspecialties and disciplines. It does seem to correlate well with the infarct size on CT brain, and it's reliable via telemedicine. And again, this is the most widely used scale right now. In order to use this, and some of you may have done this training, some of you may have not, but there are these are some links, QR codes, and websites where you can get additional stroke scale training. It is, several probably hours of videos and tests. So that's why I'm not going into too much more detail because they do it better than I could. But just as an overview, it is for acute ischemic stroke. You can use it in more the chronic setting, but it's really more guides decision making in the acute setting. There are nine, oh, sorry. I apologize for that. I'm so sorry. There are 9 domains on the neurologic examination stroke scale. So one is level of consciousness. So this is if a patient is drowsy, if they're obtunded, if they're alert. As well, language. Are they naming? Are they repeating? Can they read sentences or words on a card? Can they name things? Can they follow commands? Can they follow stick out your thumb or show me 2 fingers? Complex and simple commands. It includes neglect and extinction. We'll talk a little bit more about where that localizes if you're not aware already. But that's basically not really paying as much attention to one side of the world. It includes visual fields and extraocular movements, as well as strength in the body, arms and legs, and face, ataxia, dysarthria, and sensory loss. And you're probably thinking there are other things on the neuro exam that are not included in here, but if you think about it, this is sort of the kind of quick version and kind of condensed version that we can use in acute stroke. The items are scored 0 to 4, depending on the exam component. 0 is normal. Some things are untestable. For example, you can't test slurred speech if someone is intubated. So you just sort of put an X or just put UN or something just to kind of highlight that that was not able to be tested. And there are certain scoring items that you can and can't do that for. And this is where the training comes in handy with these links. And then it is used for both research and clinical practice and does require certification as well as recertification. And just to reiterate, a higher score is farther from normal and a lower scale is closer to a normal neurologic exam. There are various versions of even the more widely accepted modified or modern stroke scale. So this is a naming card for the pediatric stroke scale. The grown-up version, if you will, has a cactus and chair and glove. But for pediatric, they have some more fun pictures. And then the NIH stroke scale has some uh, language and culturally adapted versions. So here we have Malaysian, Korean, and Latvian, where the picture may be different. based on kind of what is more appropriate locally. The objects may be different to name, and the language obviously is going to be different. And these words in the bottom right, for example, in the first picture, those are to testis arthria. They're going to be a little bit different in every language. So interesting to see these, and there's several out there. I just kind of found these ones. So. Okay, so localization. So you're gonna, you have your normal neuro exam. You're trying to figure out is it right brain, left brain, posterior. So it's good to. So here's a sort of a sticker we've used for the stroke scale, and it shows the different aspects of the stroke scale, including level of consciousness is the first three questions. A, B, and C is, are they drowsy? Can they answer questions? Can they follow commands? Gaze deviation, are they looking to the left or to the right, or do they have a sort of a disconjugate gaze of some kind? Visual fields, so not so much what they see from their eyes, but how they're processing it in their brain. Facial paresis, motor in the arm and the leg on both sides. And then here's ataxia, and that's, whether it's in one or two limbs. And then sensory, language. So, can you understand everything they say, or understand most of, have a, decently conversation where you understand most of what each other are saying? Or is it severe where you can't understand each other in some way or have a conversation? And then dysarthria is slurred speech, which is different than aphasia, which is the cognitive part of speech. Uh, and um, and then you have neglect or inattention, where you're not really paying attention to one side of the world. So there are certain items which localize to the dominant hemisphere, which tends to be the left side. And I apologize if this is, I want to make sure I kind of describe things at all levels. So you may know all of this already, of course, but some items will localize to the dominant hemisphere more so. So let's just say the left side. And some will localize more to the non-dominant side, and some will localize more to the posterior circulation. And some are sort of non-specific. So slurred speech could be any of these three. But for example, the dominant hemisphere is going to be language. So if someone has aphasia, it's going to localize more to the dominant hemisphere, versus the non-dominant hemisphere may be neglect or anosognosia or things like this. Oops. So you can see, I'm sorry, I had some arrows on this earlier, but you can see where some of these aspects will correlate more to a dominant side versus a non-dominant side or posterior. Posterior might be ataxia, although ataxia could also be anterior circulation. It's largely posterior circulation. Okay, so just another example of using this stroke scale and kind of things to consider as you're using it. So this is again an altered image. I just had to flip it so you could to demonstrate that the same volume of stroke on one or the other side may have a different score. For the left, or we'll say dominant MCA stroke, the questions and commands and the language will all add points up. And so if those were the only symptoms one had from perhaps a global aphasia, your stroke scale would be at least a 5 plus whatever else you're seeing, gaze deviation, motor, etc. Whereas a non-dominant or right MCA stroke of the same volume would have a lower stroke scale, because it would not necessarily, someone may be able to answer questions and commands, may not be aphasic, but may be inattentive or neglecting one side. In this case, would be the left side they'd be neglecting. So just some things to think about with the scoring systems. So, some additional considerations with the stroke scale, the NIH stroke scale, it's a score that in practice may not necessarily be specific for ischemic stroke. So you may have someone who is intubated, septic, febrile, have multi-organ failure, encephalopathic, and their stroke scale might be 32 because they're weak on both sides, and they're not answering any questions. It's possible to have a very high stroke scale that's not necessarily a stroke. Additionally, it's possible to have a low stroke scale that is a stroke. So you probably have noticed that, ataxia in the limbs is included on the stroke scale. Any kind of truncal ataxia where someone's swaying around or has like a gait, ataxic gait, is not on the stroke scale, and they may not have limb ataxia. So you might have an NH of 0 that is still a cerebellar ischemic stroke. So it's important to think of the NH stroke scale in that it measures deficits, but not necessarily ability or disability. It can guide us and give suggestions, but it's not 100% concrete. Okay, so the stroke scale is a standardized, widely used score in clinical research and clinical practice. Again, it may not necessarily be representative of severity and ability or disability. It may or may not. Severity is important to consider, so that's why I'm even bringing this up when you're navigating the risk benefit of any treatment option. If someone has a non-disabling stroke, then you might not want them to undergo the risks of any thrombolysis or other acute therapies. It may also, severity may also help you consider navigating resource allocation. Do you need to transfer the patient for a higher level of care? Can you keep the patient locally because it's mild enough that you don't need all these extra acute therapies or surgeries or anything like that? It depends on what your resources are and the severity of the stroke and what can be managed. We have patients who have TIAs who we transfer from transient ischemic attack, where we transfer from one hospital to another. Yet at the same time, we have patients who can stay at another hospital and not be transferred for TIA, but maybe they transfer if they've gotten thrombolysis or they need thrombectomy or some other or neurosurgery. So there's different reasons to transfer. So severity is really important to consider when you're navigating that. And the severity can also be sort of the risk of getting worse. It's not everybody defines mild or disabling or non-disabling the same way based on the stroke scale. Just as an example, I just kind of picked one here based on some of the literature that was already being used in this presentation. So mild stroke could be less than 8. It could be less than 4 or less than 5 or less than 6. 8 to 16 is moderate, considered moderate, although some people may consider even 10 and above. And 17 and above would be severe, although some may consider 16 and above or, 20 and above. So there's different stratifications used among different clinical trials. Okay, so we're going to talk about mild stroke and then we're going to talk about severe stroke. So let's start with mild stroke. So, um, mild stroke, as defined by a stroke scale of 5 or less here, can still be disabling. So these are patients who did not receive any thrombolysis, who presented within 2 hours of symptom onset. And you can see even these mild stroke patients who have an NH of 4, 1/3 are not discharged home, and 1/3 are not ambulating independently. And then even for patients with an NH of 0, which you would presume maybe that means that there are no symptoms, 15% are not discharged home, and 16% are not ambulating independently. So mild stroke can still be disabling. So, for patients who have mild stroke, should we initiate thrombolysis or not? This is a meta-analysis where they define minor stroke as NaH of 0 to 5. And this is of about 20 trials, including about 13,000 patients. And in this meta-analysis, as you can see in this image on the left, there was not much change in functional recovery, either to MRS 0 to 1 or 0 to 2 was the other thing they looked at, mortality or recurrent ischemic stroke. But there was increased with the thrombolysis for mild stroke, increased early neurological deterioration, symptomatic intracranial hemorrhage, and hemorrhagic transformation. You can see here END is early neurologic deterioration on the top here. I don't know if you can see my arrow, but on the top one, under that is symptomatic intracranial hemorrhage. And then any other kind of hemorrhagic transformation is just under that, and the mortality as well. So some things to consider when you're making decisions. So functional recovery is not necessarily improved with TPA versus best medical management otherwise, and there is a potential for some more harm. And so we actually do have a clinical trial that looked at this about almost 800 patients where they defined stroke. And this is interesting for this study. They defined, and this is one of the advantages of doing a prospective trial. They were able to define minor non-disabling stroke as NaH of 0 to 5, plus it's also non-disabling otherwise. So, we talked about our patient in the beginning who had the NaH of 2, which is a low stroke skill, but they have a visual field deficit, which, we can talk about in a little bit, but is arguably disabling. So they had to be non-disabling. And so defining that is actually not easy. So this group defined non-disabling as less than or equal to 1 on vision, language, neglect, or single limb, arm, or leg weakness. And also the consciousness was 0. So it wasn't just patients who had an H of less than 6. It was patients who had an H of less than 6 and had these specific scoring criteria. And they found that there was a small number and comparable symptomatic intracranial hemorrhage, but that the dual antiplatelet, which was the medical management in this case for this trial, was non-inferior to thrombolysis. So it seemed that they were doing well in terms of outcomes comparably, whether they received thrombolysis or dual antiplatelet therapy, but that there were in both groups some small number of symptomatic intracranial hemorrhage. And then the other question we want to ask is, do we take this patient for a thrombectomy? If they have a large vessel occlusion and they have a small or a small stroke scale or a mild stroke, should we take them for a thrombectomy? Evidence to date is equivocal. Generally, a lot of these studies are defining NAH as mild stroke as NAH of 6 or less. The current studies suggest that there may be some early neurologic deterioration, asymptomatic intracranial hemorrhage and symptomatic intracranial hemorrhage with thrombectomy, similar to what we were seeing with thrombolysis IV intravenously, and that the there may be similar functional outcomes whether the patients who have mild stroke receive thrombectomy or not versus best medical management. And so it's clear, these are retrospective sort of we definitely need more study is warranted for this. Here is I like this because it kind of illustrates the complexity of making these decisions. And so this is a decision tree that was made for determining whether someone with mild stroke should go on to thrombectomy. And you can see it depends. Is this a proximal occlusion, a basilar occlusion? Proximal being like the intracranial I'm sorry, the ICA or the M1, or is it something more distal, a distal vessel occlusion? And then basically, do you think at that point is the patient disabled or not? And then at that point, then you want to see what the non-contrast CT shows. And if you have advanced imaging, you might want to consider perfusion imaging and just sort of a decision tree for whether to take someone with mild stroke for thrombectomy. Um, but we do have to be very cautious and intentional and thoughtful with this patient population, even though they have mild stroke and we may or may not be doing thrombolysis or thrombectomy. And so there's a decently high risk of stroke after a mild stroke or transient ischemic attack. There are several studies out there looking at this. This one was the one that kind of had the highest risk in Oxford. And so patients with TIA had about an 8% risk of recurrent stroke within 1 week, at 12% risk of recurrent stroke within 1 month, almost 1/5 or 17% risk of recurrent stroke within 3 months. And then patients with a mild stroke here defined as NaH less than 4, even a higher risk for recurrent stroke within 1 week, 1 month, or 3 months. And the authors did highlight that this is actually higher than prior characterized before. This may be attributed to earlier inclusion in the study, but either way, there is a risk certainly of recurrent events if these patients are not cared for, even if whether or not they're receiving any hyperacute therapies like TPA or thrombectomy. And then just for some guidance, there are some risk factors for recurrent stroke after a mild stroke. For patients who had TIA or minor stroke, defined here as MRS. And MRS, I'm sorry, I probably should have defined this earlier. The modified Rankin score is the disability scoring system. 0 is no symptoms. 1 is with no or slight disability, but able to perform all prior activities. 2 is mild disability, limiting the ability to perform all prior activities compared to baseline, but still independent. 3 is moderate disability requiring some help but able to walk without assistance. 4 is moderate to severe disability, really dependent on getting around or tending to bodily needs. And 5 is severe disability, bedridden, requiring constant care. 6 is death. And that's a whole nother lecture, the modified Rankin score. But for patients with MRS of 0 to 1, they had higher risk of recurrent stroke after a mild stroke if they had ipsilateral large artery atherosclerosis. So those large arteries like the proximal MCA stroke, the proximal PCA, and proximal ACA, as well as distal ICA. If the patients had cardioembolism, they were high risk of having recurrent stroke. And then if their baseline ABCD2 score was greater than or equal to 4, so the scoring system for that, just if you don't know, is if the patient has an age of greater than or equal to 60 years, that's 1 point. If their blood pressure at presentation is greater than 140/90, that's 1 point. This is for TIA patients specifically, usually, but in this case, they use it for minor stroke as well. But if the clinical features of the TIA, or in this case, mild stroke as well, included unilateral weakness or speech disturbance without weakness, so that can determine how many points they get, as well as duration of symptoms. The longer duration, the higher number of points. So patients who had a score, ABCD2 score of greater than or equal to 4, had higher risk of recurrent stroke after mild stroke or TIA. Okay, so let's switch gears and talk a little bit about severe stroke then. So, um, it's sort of the opposite end of the spectrum, and it has with it its own sort of definitions and so on in terms of what the cutoff criteria are for the NIH stroke scale. So for severe stroke, and we're talking in this case, in this study specifically, they defined severe stroke as an NIH stroke scale of 15 to 26, and a very severe as an age greater than 25. And I apologize, that should be a 25 over here. But there's question as to whether we should provide IV thrombolysis for these patients or not. So we do know that increased stroke severity, even on the stroke scale, is associated with increased risk of symptomatic intracranial hemorrhage. And as you can imagine, there's some friable tissue there, fragile tissue that's, edematous, and, it has some cytotoxic injury. And so that's a risk of bleeding into the area of the stroke. Even without thrombolysis, that can happen. But with thrombolysis, there's an increased risk of hemorrhage in that area of the stroke. Traditionally, clinical trials have excluded patients with an NIH of greater than 25, probably for that very reason. We already know that they had higher risk of symptomatic intracranial hemorrhage. But when looking at a large registry of patients with stroke, and they compared very severe to severe, they actually found no change in intraparenchymal hemorrhage, which was about 11% for both groups. They found no change in symptomatic intracranial hemorrhage, which was less than 3% for both groups. And then they found that functional dependence at 3 months was 14% for patients with a very severe stroke of NIH greater than 25, and 29% for those with the severe stroke of NIH between 16 and 25. And so you can see that as expected, this is just as expected. They have more severe stroke, they're going to have less functional dependence. But we do know that there's no excess risk of intracerebral hemorrhage with thrombolysis for very severe stroke. So it may be something you do offer in case it does help the patient. And in case they're in that, 14%. So. Okay, so let's talk about stroke severity and large vessel occlusion. And so is there a sweet spot in terms of the stroke scale and determining whether someone has a large vessel occlusion or not? Um, and that's important because they're treated differently, even medically managed differently. And so this study is for anterior strokes within 6 hours of onset of symptoms. So we know that higher stroke scales do correlate with large vessel occlusion. Is there a specific stroke scale that a good cutoff? There's not a specific one. There's a wide range of stroke score cutoffs out there that are predicted of large vessel occlusion in the literature. And though a lot of these scores that are described definitely make the disclaimer that if you use an NIH stroke scale cutoff score, you may still have missed large vessel occlusions, just as we talked about earlier, that you can have a large vessel occlusion with a mild stroke or a low stroke scale. There are some items that are more predictive of large vessel occlusion. That would include that gaze deviation. Are they gazing to the left or to the right? The visual field deficit, as we saw in our patient case from the beginning. And then motor in the arm specifically has been described as predictive for large vessel occlusion. And then aphasia or neglect. Think back to when we were looking at the NIH stroke scale, and some of these items localized to the dominant or non-dominant. So some of these, and they're usually on the cortex as well. And so in one study in the pre-hospital setting, only a quarter of patients with an NIH cutoff of greater than 10, which was sort of the most predictive cutoff that they had in their study, only a quarter actually had large vessel occlusion in the pre-hospital setting. And then from that, only a quarter went on to thrombectomy. So, and this figure is just sort of demonstrating sort of the kind of, yes, there's milder strokes. So on the left, you have 0. On the right, you have the highest score, which is 42 on the stroke scale. You can see that generally these blue lines for the lack of large vessel occlusion are for the lower stroke scale. Um, but you can also see that the LVO was sort of almost, you could see it more frequently in the larger stroke scale, but you could still see it in the lower stroke scale. So just sort of to visualize what we've been talking about. And so in settings where vessel imaging is available, clinical scores can't replace vessel imaging to predict large vessel occlusion, but they can help to sort of triage and kind of guide treatment to some degree. So large vessel occlusions generally, and this is kind of based on what we were seeing before, where they mentioned the gaze, the deviation, the visual fields, arm weakness, aphasia, or neglect. One way to kind of think about whether a patient might have a large vessel occlusion, if you are either in the pre-hospital setting or don't have access to a CTA, is do they have cortical signs and also unilateral weakness. And so I just put this flare image up. This is another adapted image that you can see the lighter part, the cortex, and the inner part, the white matter disease is darker. And so, what are cortical signs? It could be language, so aphasia, not slurring of speech per se, but actually the cognitive part of either getting the words out or understanding. On the bottom on the left, you can see neglect, which could be anosognosia, agnosia, ignoring one side. That's usually right brain or non-dominant. But other cortical signs can include visual fields and gaze preference or gaze deviation. So that's kind of those, usually a large vessel occlusion will usually, not always, include those cortical signs. Additionally, with the unilateral weakness, some other indications that the patient might have a large vessel occlusion versus a small vessel occlusion would be that not only do they have unilateral weakness, but that either the arm weakness is greater than the leg or the leg weakness is greater than the arm. And that's just because of where the arm and leg are located on the homunculus. Whereas a small vessel stroke, again, usually will have similar weakness in the face, arm, and leg all together at the same time. So just some kind of thoughts about how to determine if a patient has a large vessel occlusion or not. And so this leads to some pre-hospital large vessel occlusion screening scores. So these concepts are the basis of the pre-hospital large vessel occlusion scores. There are several out there, and that's probably its own separate topic. But here's the VAN score, which is vision, aphasia, and neglect. So if you remember from the prior slide, those were some of the cortical signs, but also weakness. So, and this is used in we use this often in our pre-hospital setting, and again, this is one of many pre-hospital scores. But we use this in the pre-hospital setting, and so the first question you ask is, is the patient weak? And on the VAN score, there's a mild, moderate, severe, but any level of weakness counts. And then does the patient have a visual disturbance? Is there a field cut? Is there double vision or blindness? Are they aphasic or do they have neglect? And so if you have one of these VAN or VAN or vision aphasia neglect symptoms and you have weakness, then you have a positive score. And this score specifically has been shown to have up to 100% sensitivity for LVO and 90% specificity. So. I know that we focus on a lot of acute stroke therapies, and I also know that thrombolysis and thrombectomy are not always widely available everywhere. So I did want to take this opportunity to sort of highlight this program, Mission Thrombectomy. This is their mission is to promote global access for stroke treatment. This is through the Society of Vascular and Interventional Neurology, which is a professional organization. They have lectures and so on. Just putting that out there that you can watch. But this organization specifically leads to, there are ambassadors to different countries which seek out further development of specifically acute stroke care, but also prevention, pre-hospital, all the kind of different aspects and spectrum of stroke care. And they focus on expanding thrombectomy and also thrombolysis in areas that don't have access to that. They also focus on pre-hospital triage and recognition of stroke in the community and for providers. So let's return to the case. So we have our 67-year-old who has diabetes, hypertension, congestive heart failure, who arrived to the ER within 1 hour of quote unquote blurry vision. And I'm sure we can all attribute or attest to the fact that blurry vision can be many different things. It could be a field cut, it could be just sort of haziness, it could be one eye, central retinal artery occlusion. But bilateral blurry vision, would you consider TPA for this patient? And again, you're probably asking, well, what are the stroke scale points for? In this case, the patient has a left visual field cut. So in this case, the patient did not receive TPA. The exclusion criteria that were documented were mild symptoms, which if depends on how you define mild. The NIH stroke scale is low, but the workup did reveal, and it's a little subtle here, and this is also an adapted image, but there's a right, you can see it's darker here on the CT scan. It's a right PCA stroke. And the vision changes improved minimally by discharge, which was a few days later. So just, kind of think to yourself, how can a left visual field cut or homonymous hemianopia limit a patient's ability to perform activities of daily living? Certainly, if a patient was driving, they would not be able to drive at this point. Now, patients can get better from stroke, as I'm sure you've seen. So, only time will tell, and they can always get tested. Ambulation can be hard, right? Because there is such a thing as, vision therapy. And so the patients might, start, if they can't see a wall, they might run into it. So ambulation can be difficult. Simple things as, we think about every day, like eating dinner. If you can't see half your plate, you're probably not going to really be able to, eat well. And so these patients will still require therapies and rehabilitation, and may or may not be able to return to the workforce depending on their line of work. So just something to think about when you have patients with these sort of lower stroke scales. I wanted to just put in a plug for prevention. I focused a lot on acute therapies, and I think, that's, all fun and good. But, if a patient's not either on a secondary prevention plan or had a primary prevention plan and didn't have a stroke in the first place, we haven't really done our job. So there are a couple of resources here for guidelines on prevention, and it may be, good to have a talk at some point on from a prevention expert to talk about stroke prevention. Um, and so, in conclusion, from mild to severe stroke, there are acute treatment options. Stroke scoring can be helpful in research, but also clinical practice in the appropriate context. Stroke severity is important to consider in medical decision making, but we still have a lot of room left to understand what treatments are appropriate in what patient populations and what settings. And that's all that I had. So I just wanted to thank, I just stole this image from the Health for the World website. I hope that's okay. I just wanted to thank you for inviting me for this talk, and also for your program. It's, I think, one of the best ways to improve healthcare is education. For patients, for clinicians, for, everybody. So I think it's a great program, and I really enjoyed the opportunity to speak to you all.
Excellent. Thank you so much, Dr. Jagolino-Cole. We really do appreciate your time and your expertise and such a great and thoughtful presentation. I think at this time we will open up our Q&A session for our panelists, and then we can transition to those who have written questions in the chat.
Should I go ahead and address the questions in the chat, or?
We can. Let's
Okay.
see. Looks like we have two. The first question is asking on how you determine which hemisphere is dominant.
Sure, that's a great question. So, generally, the left side of the brain is the dominant hemisphere in almost all right-handed patients. And the right hemisphere is the non-dominant hemisphere for right-handed patients. And so that's kind of how I remember it, knowing that it's obviously the opposite for left brain patients, although left-handed patients, sorry, left-handed patients can have it kind of either way. So
Thank you. I think we have a question from one of our panelists, so we can pause and give them a chance to speak.
Hello, sir.
hello.
Good afternoon, sir.
Afternoon.
Hi.
Yeah, this is Dr. Dan from Bingo. Thank you so much, Dr. Nicole, for this wonderful presentation. I had two questions. Uh, the first one was, what is your comment about the use of other skills that have been shown to also be highly predictive of the mortality of strokes and also very easy to perform relative to the NIHSS score? And secondly, how I know initially you mentioned reliability of the NIHSS score with test and retest reliability, but I wanted to find out how applicable that is in a logist. In our set
I think it got cut off, but I think your last second question, just to
stroke
clarify, was,
scale.
oh, sorry. I missed the last question. Would you mind terribly repeating it? I just want to make sure I address it.
Uh, the last question is about applicability of the NIHSS score in a setting without a neurologist or in a non-neurologic clinic, like in our setting where we are just internal medicine physicians. So I wanted to find out how applicable this is, given that it's very cumbersome sometimes to perform. And the duration you gave of 6.6 minutes, apparently, if we have to perform it in this setting, it becomes very, very lengthy. So thank you. Those were my two questions.
Sure, certainly. Those are great questions. Let's see. So in terms of other scales, so there are a lot of scales out there. The scale was developed, the current NIH stroke scale, let's see, from what I understand, hearing from the people who developed it and who ran the initial NINDS stroke trial that demonstrated benefit for select patients for TPA or thrombolysis for stroke. The part of so the NIH stroke scale that was used then was is the one that we use more often now. The wide acceptance of it is attributed to a couple things. The inter-rater reliability, the test-retest reliability, the interprofessional reliability, interdiscipline reliability, but also it was used in that trial. And so this is probably more anecdotal. And there are more expert people who can kind of comment on this, or the people who were there. But part of the reason it's used so much is because it was in that original, it was what was used in that original NINDS trial. That was in 1997. That was the trial that showed us that there was benefit again for TPA for select patients. And so after that trial, it really opened up the world of stroke. And and the things we can offer for acute therapy for stroke. And because of that is what I understand part of why the NIH stroke scale was started to widely be used not only in the research settings on further research on acute stroke, but also in the clinical setting to a point where for our kind of like stroke measures, quality measures, it's actually something we include in our documentation when someone's admitted with a stroke, whether or not they get TPA, whether or not we even considered. Maybe they were a 48-hour-old stroke and they were not eligible for TPA. We still use a stroke scale because we are to document that to demonstrate quality, particularly if the patient gets worse, they can compare the NIH stroke scale sort of as a sort of quick and dirty way to, if you will, to compare worsening or improvement, and sort of the severity of patients who are being admitted to a hospital. So the wide use of it is, it's a great scale. I mean, no scale is perfect, right? I mean, even the people who developed the scale would probably say that. But it's just widely used for those reasons. And I'm sorry, my lights just turned off. There are other scales. So there's a Canadian scale that's also used a lot. There's the one that we use mostly now is a modified stroke scale. But there were several stroke scales that either evolved into the stroke scale as we see it now, or were kind of developed maybe concurrently, I believe. And so there are other scales to use. One of the things that I've heard comment, and this is again anecdotal, but I've heard commented about some of the other scales as they might include some items that may not necessarily change management, like pupillary dilation that can take a long time to sometimes check on a patient and may be confounded by medications if they're intubated and things like that, if they're on, any sedatives or analgesics, and reflexes, things that may or may not that may help you determine where the lesion is in the brain or spinal cord, or whether it's neuromuscular or spinal, but may not necessarily guide acute decision making. So there are other scales that include more detailed items of the neuro exam, which I agree is very lengthy. It takes me still, I mean, I'm 10 years into this and it takes me a long time to do a full stroke scale. I mean, a full neuro exam, but the stroke scale is a condensed version. So there are other scales for sure. And then the VAN scores have been used in the pre-hospital setting. For example, if a paramedic is coming in on an ambulance to the hospital and to the ER, they can say VAN score positive, and then that helps in their kind of pre-notification for the ER, and then the ER can therefore start thinking, okay, are we thinking large vessel occlusion? Do we need to start thinking about transfer or thrombectomy or things like that? So definitely other scales, and I hope that sort of helped answer some of the question about like why the NIH stroke scale that we use now. And let me know if that didn't answer your question, please, of course. And then in terms of the test retest, the study that I used in that slide specifically looked at nurses and doctors, looked at ER and neurologists. I apologize, I'd have to go back. I don't think they included hospitalists or internal medicine inpatient doctors, but I don't see any reason why it would not be able to be used in by internal medicine specialists. I think it's kind of it seems to have good test retests among kind of just anybody who uses it, because it does really sort of condense that neuro exam, and you don't have to like know how exactly to do like a full confrontation motor exam or reflexes and things like that that can be cumbersome when it's not, let's say, necessarily your subspecialty. I hope that did I answer your question or your questions?
Yes, you did answer the questions. Thank you so much for your input. Please, I wanted to find out as well, in terms of large vessel occlusion, what's your take, given that we are not in a thrombolysis or thrombectomy capable center? What is the best management approach medically for this
Mm,
patient?
mm.
In terms of anticoagulation, dual antiplatelet therapy. Yeah, so in that light, what's your encouragement or medical advice for us in this kind of setting if we have a patient with what we suspect is a large vessel occlusion or a severe is acute ischemic stroke?
That's a great question, and I think deserves a whole separate talk. But I can address it to some degree because we see this day in day out. So in the acute phase, if you don't have access to thrombectomy or thrombolysis, some things that can help is laying the head of bed flat to allow perfusion into the brain. Some more giving fluids to kind of, as long as the patient doesn't have any contraindication to having fluids. I know that, even patients with severe heart failure can have stroke. So you have to be careful in some patient populations, but giving fluids, sometimes if someone is fluctuating and we haven't been able to open up the clot or send the patient for thrombectomy, we'll try to give like a bolus if they're getting worse, or give fluids to kind of keep that area perfused. Obviously you can't do that, long term, but it's a way to kind of see, if someone's acutely worse, either a new stroke or new worsening. That is a way to kind of see if they're getting better, or if they can get better, or if you can help them improve. And then in terms of how do you treat an large vessel occlusion sort of for secondary prevention, it really depends on the cause of the stroke. And I keep saying this, I'm so sorry, but I'm sure we can all talk for hours about our own specialties, right? So as I'm sure you could for internal medicine, for me, but it really depends on the cause of the stroke. So there are different kinds of stroke. Generally, we look at small vessel stroke differently than large vessel and so on. But for large vessel occlusion, most of the time, the causes are either some sort of cardioembolic source. Or it could also be intracranial atherosclerosis that has had like a vessel that has had atherosclerosis for a long period of time and just sort of either shut down or had a sort of acute kind of thrombus form on top of the plaque. And so I don't, it depends on the cause. If it's AFib, we do know that anticoagulation can help, but do you give that, in the acute phase for a new stroke? You might have to be careful because if there's a large stroke, you can again bleed into that area of the stroke. So you have to be careful when you're doing these things. But anticoagulation can be used for uh, cardioembolic stroke, specifically AFib. Some cardioembolic stroke you would not use anticoagulation, so it depends on that too. Versus large vessel atherosclerosis, whether it's from the neck or the intracranial arteries, you might do antiplatelet or dual antiplatelet. So it really depends on the stroke. And these are more for prevention, more so than or secondary prevention more so than primary prevention or acute treatment. Like they're not lytics, like TPA or is where they won't actually break up the clot in the acute setting likely, or they're unlikely to. So did that answer your question?
Yes, you did. Thank you so much.
Of course, thank you.
Another quick question from one of the colleagues here.
Yeah.
He wanted to find out if visual loss, aphasia, as well as neglect, which were mentioned to be suggestive of large vessel occlusion, must occur together, or you can have each apart and that will still make you think of a large vessel occlusion, or you need to have all three occurring together before you can make that suspicion.
That is an excellent question, and I should have clarified when we were on that slide. I apologize for that. You just have to have one of those. So you need one of the visual loss or impairment or aphasia or neglect, and you need any type of weakness for it to be positive. So you don't need all three together. You need just one. So if you have visual loss, like say they have a visual field cut and they have weakness, that's more indicative of a large vessel occlusion than just visual loss alone or weakness. Now, again, this is a score, and it can miss things just like any score, but that's just sort of what we use to triage. But yeah, you don't need all three at the same time. It's a good question.
Yeah, it does. Thank you so much.
Thank you. Thank you for listening.
And it seems like we have a couple of questions that were written. The next one asks if the NIHSS is a reverse score. For example, would a score of 9 be more normal or a better score than a score of 6?
Yes, and that yes, that's a great question. So the lower the score, the closer to normal you are. So an NH of 0 is a normal exam. Now, one caveat that's important to include in light of this question is if I've had an old stroke and I have arm weakness that was an NH of 2 and remains an NH of 2, and then I have leg weakness now, the score will still include the old symptom. So my score of 2 may go up to I'm just making something up off the top of my head right now, but we'll say my score of 2 on the arm will go up to a 4 total, including the leg, but the delta or change in NIH stroke scale is 2. So therefore, I'm worse now that my stroke scale is 4 in this scenario that I painted myself. But the lower stroke scale is closer to normal, and if someone has had a stroke, the closer to their original stroke scale they are, the closer they are to their baseline, if that makes sense. So okay.
And I think a follow-up to that question, if a patient has a low NIH stroke scale score or a decreasing or improving NIH stroke scale score, but they have a major functional deficit, would that patient be eligible for thrombolytic therapy?
Let's see. It depends. So if it's disabling, I would say yes. So on our hypothetical case with the visual field cut, then I probably if I was the one seeing that patient, if they had no contraindications, they were in the window, I probably would give thrombolysis to an NaH of 2, even if it was disabling. Let's say it was. Uh, I mean, an H of 1 for numbness, I might, this is all hypothetical, but depending on the case, I might not for NIH of 1 that's numbness where it's not disabling to the patient. And I realize what's disabling to patients may also, be sort of personal as well, but so that's always something you kind of think about when you're making decisions. But and then if they're improving, it depends. So and this is me just sort of talking about my own clinical practice rather than evidence-based medicine at the moment, but I would say if they're improving to a point where they're close to their normal baseline and can perform the functions that they could perform beforehand, then I might not use thrombolysis. But if they were improving but still to a point where they were still like let's just say their NH was going from like a 6 to a 4, but they still have a 4 and it's still for, arm weakness, I might in that case, a hypothetical case, give thrombolysis. So I think the important thing to think about is this disabling? Now, we know that TIAs, even TIAs and also mild stroke can still leave, even if there's not an overt, oh, their stroke scale 0 because they don't have drift in their arm, there may still be some long-term cognitive sequela to having even a mild stroke or even a TIA. We think there is still some damage even actually with the TIA, is what we're thinking now. So, it's sort of a tough question to answer because I mean, you probably could argue that any stroke scale would lead to some sort of disability, but it's sort of a risk benefit thing. So, like, if they're more likely to have bleeding, then you might forego it if they're close enough to their baseline. So I hope that answered that question. And then, yes, so to the, I can't remember the third or fourth question, but to the next question, would you suggest other scales or modifications in the NH in assessing posterior circulation stroke? That is an amazing question. And yes, there is actually a posterior circulation NIH stroke scale that I should have included. That would have been really good to include, because it is very true that you can have an NH of 0 and still have a disabling stroke from the posterior circulation. So excellent question. But yes, there is a posterior circulation NIH stroke scale. I would say anecdotally, we don't quite use it widely in clinical practice, maybe yet. Maybe it will be, who knows? Only because when someone's coming in, we don't know if it's anterior or posterior. And one thing you could do is say, well, their stroke scale is low, but they have these posterior circulation symptoms. Maybe we should do the posterior circulation stroke. It's not used widely enough for me to be able to say, like, let's just say I see a patient on telemedicine and I use the regular NIH stroke scale, or say I even use the posterior circulation stroke scale. I don't know if I transfer it somewhere, if that patient's worse or better. It can be a little jumbled there. So I think we still kind of use the classic or modified stroke scale. But yeah, but there is one, and I apologize for not including that. A great question. And then the last one, patient with global aphasia, no motor weakness. Okay. Um, Oh, let's see. That's a great question. So in this case, as I understand it, and please correct me if I'm wrong. So patient who has global aphasia, so they can't talk well, they can't communicate because they can't express themselves, but they also can't understand the global aphasia. But they have no weakness. Does that mean they have worse prognosis than a patient with intact language, but just dense hemiplegia. Like I'm assuming that this means not moving the arm and leg on one side. Um, Gosh, that is a great question. I think that in terms of prognosis, it in this case it may not. It just depends because there's sort of different kinds of disabilities. Almost a philosophical question, which I love. So the patient who has global aphasia can both of them could improve, I guess. But I would say the prognosis really depends not so much on the symptomatology as, again, we've noticed that generally, not all the time, but generally higher stroke scales, if they remain high after any acute kind of treatments, do lead to worse prognosis or worse outcomes. So I think it's more about severity, and this brings up a good point, is that your NIH stroke scale might be, almost equivalent between global aphasia and having dense hemiplegia. The number might be the same. Um, but there are two different types of disability as you're alluding to it in the question, I think. And so I guess it's sort of I can't say that they necessarily have a worse prognosis. It also depends on who they are. If a patient uses speech a lot in their job, which, most people do, then it might be harder than someone who does a lot of heavy lifting and things for work. So I guess it kind of just depends on the patient, kind of their baseline, the patient, and how severe their symptoms are in terms of their abilities. And that's where NIH may not help us distinguish between the level of disability in this case, because they could have the same NIH stroke scale in both of these scenarios. I hope that answered that question, but opens up a good discussion anyway. So
Excellent. Thank you so much for fielding so many questions from our audience. I
appreciate it.
believe that that will conclude our webinar on today. Again, I just want to extend thanks to you, our speaker, for sharing your knowledge and expertise with us, and also to all of our attendees. That will conclude our webinar. Thank you all so much.
Thank you. All right, take care.